welcome everyone. We'll go ahead and get started. I am Katie Menson. I'm a member of the Assembly's Web Committee and Associate Professor at the University of Vermont in the US. Before I introduce today's article and panel, I'd like to kindly ask that all attendees mute their microphones, as this is a recorded session. When we reach the discussion segment, we'd really like a lively discussion. So we would appreciate questions and comments that you have. Preferably, we like to hear from you in person. To do this, you can raise your hand, which is found in the reaction section, and then you can unmute your mic. If you need any help, we can assist you in unmuting. Alternatively, feel free to put a question in the chat function, and myself or Dmitry will read it aloud. You can also tweet your question to our Twitter handle at PR_assembly, and I'll read it out loud. The article we're discussing today is entitled "The Clinical Effectiveness of an Online Supervised Physical and Mental Health Rehabilitation Program for Adults with Post-COVID Condition," called the REGAIN Study, a multi-center randomized controlled trial by Gordon McGregor and colleagues from University Hospitals, Coventry in the UK. It was first published online at the BMJ in February of this year. Enya Daynes from the University Hospitals of Leicester NHS Trust will present the article. Today's expert panel members are Tania Janaudis-Ferreira. I'm sorry, Tania, if I didn't say that appropriately, but coming to us from McGill in Canada. And we also have Glöckl from Germany joining us as well. So now Anya will present the study. Thank you.
Thank you. I'm just going to load up my slides. Bear with. Okay, I will trust that you can see that unless somebody yells out at me. Thank you. So this is a huge study to cover in just 15 to 20 minutes. So I'm going to do my best to do it justice. But it was conducted just down the road from me, actually, in Leicester, down near Warwick and Coventry. And yeah, it's the REGAIN study that I'll be presenting. So just for a bit of background, I will refer to the study population as those with long COVID. For convenience more than anything, and to define that, I'm considering that for people who have had symptoms that have lasted 3 months or more. There are variations in that definition, but for the purpose of this session, that's what we are thinking about. And it won't come to a surprise to the audience that this is a huge problem. Particularly in the UK, we have some data from a cohort study that showed that 7 out of 10 people that were hospitalized at the time of their COVID still experiencing debilitating symptoms at 5 and 12 months post-discharge. Globally, it's estimated that 17 million people are living with long COVID or similar condition. And in the UK alone, that's approximately 1.9 million people. So there is a huge burden, and particularly a huge burden in the UK. The symptoms of long COVID are very vast as well, so it makes it a very complicated condition to treat. There's some multi-organ involvement, and results in kind of over 200 symptoms have been reported to be associated with long COVID. What we know from pulmonary rehab is that there are a lot of symptoms where there are some overlap with kind of chronic respiratory conditions, and I know I'm speaking to largely a respiratory audience, but people who are breathless, have fatigue or limitations in their ADLs, reduced strength, frailty, etc. We have demonstrated in pulmonary rehabilitation literature that we can support these people in their recovery. And so it's not a huge leap to consider that maybe similar strategies can be applied to those living with long COVID. To date, the long COVID literature is largely uncontrolled data. And I think this is one of the first large randomized controlled trial to explore this population. So the authors highlighted their aim to evaluate whether a structured online supervised physical and mental health rehabilitation program can improve health-related quality of life compared to usual care in those with long COVID. And this was a pragmatic multi-center parallel group superiority randomized controlled trial. It was conducted in England and Wales, which is the lighter pink on your map for those who aren't familiar with the UK. And these people were identified by patient identification centres in England and Wales. They were also identified through NHS Digital, a platform called DigiTrials. This will invite anyone. It doesn't necessarily pick out those people that have long COVID. So just bear that in mind when we look at the consort diagram later. And people were also able to self-refer by expressing interest as well. And they were obviously appropriately screened before they were included. So important to highlight, this was, I guess, kind of a decentralized trial design in that it was delivered largely remotely. And that is, I guess, partly because of the landscape that it was operating in. This was set up during, various lockdown restrictions. Those that were considered included, so adults aged between 26 and 86 years old, they had to be hospitalized at the time of their acute COVID event, and they had to self-report ongoing substantial COVID-19 symptoms, either physical or mental health sequelae. The exclusion criteria is fairly sensible. Those that are contraindicated to exercise, or if they have severe mental health concerns, if they've been previously enrolled in the study, because of the multiple options in which they could have been referred, that is possible that could have happened. Or if a household member had been on the trial, because obviously the two groups and there would be cross-contamination, or if they're engaged in an alternative rehabilitation program for treatment of this condition or similar condition. Randomization was stratified by age, so less than or more than or equal to 65, based on their level of hospital care and their mental health symptomology, so using the impact of event scale and HADS as cutoff points. So this is just a rough idea of the study timeline. So people that were invited or submitted an expression of interest were contacted and screened. Their consent and study visit was all delivered online. They were then randomized on a 1:1.03 ratio in favor of the intervention. Then there was an intervention phase, and I will explain the interventions in a moment. And they were followed up at 3 time points, again, all delivered remotely, so at 3, 6, and 12 months. The control group is described as best usual care. I guess important to note that usual care varied substantially over the time that this trial was delivered, and still actually continues to vary substantially. But in this instance, it's described as a 30-minute one-to-one consultation, using the Your COVID Recovery website as kind of a template for this assessment. And then they were provided a trial booklet, which was based on the Your COVID Recovery website handout. At the time of this study, this was public-facing information, so would be considered usual care. The consultation covered advice on how to facilitate recovery and self-directed return to activity. The intervention was an 8-week online home-based supervised group rehabilitation program supported by a workbook. This commenced with a 30 to 60-minute one-to-one consultation, similar to that described of the control group. And then they were enrolled into weekly online practitioner-led sessions. This was delivered by a regain practitioner, typically a physiotherapist or a clinical exercise physiologist. This was synchronous, so this was a live group session. And they also had 6 online group psychological support sessions that were 1 hour each, using the Beam platform that has been used in chronic kidney disease, and that was delivered on Zoom. The exercise component in this program was individualized equipment-free exercise sessions performed under the supervision of this practitioner, as I say, was synchronous. And the aim was to improve cardiovascular fitness, strength, balance, and fatigue, whilst improving confidence to complete activities of daily living. The psychological support sessions were semi-structured and, as I say, supported by a practitioner, designed to enhance the capability and increase knowledge and understanding of their condition and how that's impacted their day-to-day life. This began with a short introductory video and covered topics of motivation, fear avoidance, activity pacing, managing emotions and setbacks, sleep and fatigue, stress and anxiety management. And these groups really supported and facilitated sharing experiences between participants. Lastly, the intervention group had access to an online on-demand library of physical activity to support a kind of home independent program, and this varied in intensity from kind of light, gentle stretching and breathing exercises to more intense aerobic exercises. The primary outcome for this study was the PROMIS preference score, and the primary endpoint was at 3 months. For those not familiar, this is made up of several domains, and is a kind of global health measure. It is recommended on the NIH website on their portfolio. The domains include fatigue, sleep, pain, interference, physical function, social roles, and cognitive function. And it's a preference score, so you kind of amalgamate all of these domains, and the range can be from -0.022 to 1, 0 indicating a health state equivalent to death, and 1 indicates perfect health. So those that are familiar with the EQ5D utility index, there are some parallels with that. The MCID that I've indicated on the slide of 0.03 to 0.05 is derived from similar preference scores, such as the EQ5D utility index, because at the time of this study, there wasn't an MCID for the PROMIS score. Importantly, this outcome measure is validated for online use as well. They also did collect the raw data and use standardized subscores. So they do look at those individual domains that I've described, and I will share the results of those as well. As part of the PROMIS score, you can also complete a dyspnea short form, a neuro quality of life short form, looking at cognitive function. And in addition to the PROMIS score, they looked at physical activity measured by the IPAC, the impact of event scale, looking at kind of post-traumatic stress disorder, anxiety impression measured by the HADS, and overall health was self-reported compared to baseline. And they also looked at mortality, adverse events, and serious adverse events were monitored and recorded, and they had prospective monitoring of post-exertional malaise and post-exertional symptom exacerbation. And so the sample size was calculated for a moderate effect size of 0.3, indicating a total of 535 participants. And as I indicated earlier, the randomization is slightly in favor of the intervention, so expecting 272 people in the intervention and 263 in the usual care group. They used intention to treat as their statistical analysis method, using a linear regression for their primary endpoint. They include an adjusted and unadjusted analysis, and we're adjusting for age, level of hospital care, level of mental health disorder, baseline PROMIS score, and therapist effect as the random effect. They also do a complier average causal effect estimate, comparing those that fully or partially adhered to the intervention to those that would have been deemed adherent in the control group if they were assigned to the intervention. And they had predefined subgroups based on age, so less than or more than equal to 65, level of hospital care, so that's those that received high dependency unit or intensive care unit support compared to kind of ward-based care, stratified by the HADS score of 11, same with the impact of event scale. Ethnicity, they compared white versus non-white. They were also able to look at subgroups for each wave of the pandemic, ranging from 1 to 4. And they also compared the method of recruitment, so self-referral, referred through these patient identification sites, or referred through NHS Digital. And they also did some sensitivity analysis where they did impute for missing data to ensure there were no differences. So as I say, a massive piece of work. So I've split this consult in half because it's huge, but let me draw your attention to some aspects of it. So they randomized 298 to the intervention, and sorry, I can't actually see on my screen because I can just see my own face. Let me hide that. 287 to the usual care. Approximately overall, there's about a 20% dropout at 3 months, which I think is probably similar to what we'd expect in pulmonary rehab intervention studies anyway. So I wasn't really alarmed by that as a number. There was slightly more in the treatment group compared to the usual care group. Sorry, I've reported that. That's 20% was in the treatment group, 12% in the usual care group, again, to be expected. But overall, it was 16% dropout, which at 3 months, which I think is probably fair for this type of intervention. That did leave them slightly underpowered at 3 months, with 487 people to analyse, needing 535. But as I say, they do multiple imputation, so that analysis would be adequately powered. I have redrawn this baseline characteristics table because it is huge. So I do encourage you to read the paper because there is a wealth of information. And I've just picked out some of the information that I thought people would like to see and what I guess I'm drawn to when I look at these kind of papers. So I think the age of the groups are sort of what we're expecting for this population. A reasonably even gender split. Very few non-white ethnicity. Again, I think that is quite reflective of what we see in this population. A high BMI, and around 35% of people were admitted to intensive care. And there was approximately 330-ish days since their initial discharge. But as I say, I do encourage you to look at the baseline characteristics table in the paper. Overall, about 1/3 were considered overweight or obese, and 1/3 admitted to ICU or HDU, as they've highlighted. The most common pre-existing medical condition were respiratory or breathing conditions, and importantly, 1/3 of patients were unable to work as a result of their COVID symptoms. So let me take you to the primary outcome. I haven't redrawn this one, so I could fit this one on the slide. So importantly, health-related quality of life improved in the intervention group over the usual care group at 3 months. This was driven predominantly by changes in depression and fatigue subscores, which I will show you the graph of that in a moment, and the pain interference score. And this effect was also evident at 12 months, but not at 6 months. If you look at the column that says case, that's the complier analysis that I mentioned, the effect is even greater, which is slightly what you expect. If people do the intervention, they do get better. And again, this is significant compared to usual care. And I have also added the graph in there where you can see the improvements, slightly losing its significance at 6 months, but maintaining it at 12 months. Okay, and this, again, I've had to cut this figure in half. There's only so much I can put on the slides, but it's actually, I think this is a really nice way to visualize the changes. And I drew your attention initially to the 3 months part. And as I mentioned, you can see this was predominantly driven by fatigue, pain interference, and depression. All except cognitive function are on the favors the intervention. So I should highlight the right side is favors the regain intervention, which you can see on the second half of the figure that I've chopped off on the right there. So it's only cognitive function that doesn't favor the intervention, but several of those do cross the line of no effect. And this is, as you can see, similar at 6 months. Those social roles slightly crosses the line there too. And then you can see again at 12 months, depression, fatigue, and sleep disturbance are kind of driving that change. Sorry, I'm just recovering from an illness, so I'm surprised I'm getting as far through as I am without causing a fuss. I've just reported some of the secondary outcomes at 3 months, as I say, just in the interest of time, really, and this was the primary endpoint. But the improvements are in favour of the intervention, and this was noted for the EQ5D visual analog scale. That's the 0 to 100 scale of health status. So that was significantly better in the intervention group over the control group. And that was seen at 3 and 12 months, and the same for the impact of event scale in favour of the intervention group at 3 and at 12 months. Excuse me, I'm just going to clear my throat.
Take your time, Anya. No problem. This will give me an opportunity to say that as I was quickly running through my script earlier, I left off, Rainer. I'm sorry that you're joining us from the Institute for Pulmonary Rehabilitation and Research. So thank you, Anya, for the opportunity to go back and fix my mistake.
Sorry about that. Can you still see my slides okay?
Yes.
Yeah, okay. The health status aspect, 17% of people reported much better health now in the intervention group compared to 8% in the control group. And that indicated a number needed to treat of 11.9. And if we grouped somewhat better and much better, that increased to 51% reporting that in the intervention group and 32% in the control group, reducing the number needed to treat to 5.4. People in the regain intervention also had a higher odds ratio of being physically active, so 66% more likely to be physically active compared to the control group. And there were 7% more participants meeting UK guidance on physical activity after the regain intervention. Importantly, adverse events were very few. There was only one serious adverse event reported that was related or possibly related to the intervention. And that was an episode of syncope and vomiting 24 hours after the intervention. There were two related adverse events, one being knee pain during the live session and one anxiety during the live session that were considered related to the intervention, and two possibly related, again, reporting anxiety and a headache during the live session. But I'd say these are reasonably few for a trial that's this large. And I think that's really encouraging, because a lot of the concerns around these type of interventions in long COVID is that they may cause harm. And I think this just shares that this isn't the case if we select the right population. Importantly, they also didn't report any instances of post-exertional malaise or post-exertional symptom exacerbation during the trial period either. I won't spend too long on this because, as I say, I've already taken up a lot of your time, but there weren't really any differences in the results from these predefined subgroups. And although there were significant changes seen when adjusting for additional covariates of sex, BMI and ethnicity, and importantly, after multiple imputation. So there were some differences, but actually the mean didn't change in either of those incidences, still reporting a mean change of 0.03. So I will just wrap up by highlighting the strengths and limitations of this study. I think this is a huge undertaking and a really nice example of how we can decentralize trials and do so efficiently and to great effect, with recruiting over 500 patients in a reasonably short amount of time. And I think as a rehab professionals, we often shy away from kind of decentralized trial designs, but I think this is a really nice example of that. It is individualized and tailored to the individual. And because of the lack of assessment, though, we weren't able to prescribe the intervention like we would potentially do in pulmonary rehab. The online delivery potentially increases accessibility and rollout in this population, but there may be some kind of digital exclusion. But with these types of interventions, I think having options is always good, and this is a nice, effective option. Sorry if you're wearing headphones. 1 second. I would just highlight having a multifaceted outcome measure like this means that if you have an element like, for example, the cognition element of this questionnaire, it might dilute the effect of the intervention, but actually you can kind of understand why that was selected in this group where the symptoms are so vast and variable. And it's just to note that actually we might be underestimating the impact of this trial. They have demonstrated clinical significance, and since this publication, the authors have noted that there has been an MCID established for this questionnaire, which was 0.04. So this intervention is slightly underneath that, but the complier analysis does actually exceed that. So I think that's important to note as well. I'm going to leave it there so that I can coughing piece, but thank you very much. Just to conclude, people with long COVID and at least 3 months after their hospital discharge, excuse me, have improved their overall health-related quality of life following the regain intervention more than that of usual care. And this was maintained at 12 months as well. So thank you very much for your time.
Enya, thank you so much for getting to that, and I'm very sorry. But we appreciate you going through such a robust amount of data. So I would like to now open it up for discussion. If anyone has any questions to start, feel free to raise your hand and unmute. I think one thing I wanted to just, oh, go ahead, Rich.
I just can't help but mentioning that this is seems to be one kind of long COVID, they're mostly people who are, a lot of them in the ICU, a lot of them with respiratory symptoms specifically, and no post-exertional malaise. It seems like there's a very large population of patients who have the chronic fatigue syndrome OID symptoms, and this study didn't seem to at least predominantly include those. So while the results are valid for who they studied, it may not be the widest group of post-COVID, long COVID patients. Thoughts?
So, so I wasn't sure actually if that was, I don't think that's aimed at me, Gordon, please do correct me if I'm wrong, but they weren't excluded for having that as far as I understood, but they didn't note any of it as well.
I do agree with that. And I saw that they excluded contraindications in exercise program, which might exclude people with post-exertional malaise, but I noticed very few were excluded on that basis. So I don't think that's necessarily the problem.
Tanya or Gordon.
Shall I come in there?
Yeah, go right ahead.
Thank you, Richard, for your question. And thank you, Enya, for struggling through that. It's a very odd situation when there's somebody else presenting your work, but thank you for being so kind. Richard, completely agree. This is a subset of people with long COVID. And this has been one of the criticisms of the work, although I don't feel it is a criticism because we were upfront right from the start to say this is the population we are studying. We didn't exclude people who had symptoms consistent with post-exertional malaise at baseline. We didn't exclude them. There wasn't at the time an adequate way of screening or assessing whether people had post-exertional malaise or not. But we were able to discuss with people their symptoms to see if they seemed consistent. So we made a note of those people who may have been experiencing some degree of post-exertional malaise. But during the trial, there was no instances of people reporting that their engagement with the trial in any way had led to post-exertional symptom exacerbation. So I think my gut feeling, although this can't be proven in any way formally or objectively, but there were people on the trial who had post-exertional malaise, but the intervention itself did not exacerbate that. We were very careful in screening for these symptoms, but what I will say is that, and you highlighted this, is there were slightly more dropouts in the intervention group than the control group, and we don't have reasons for dropout for all of them, so we can't exclude the possibility that some people did drop out because they were experiencing post-exertional malaise. So that's the caveat, really, but I think we were pretty confident that the population did include people with post-exertional malaise, but the intervention did not seem to exacerbate that.
Go ahead, Tanya.
Hi, everyone. I just would like to congratulate the authors. A very, very large study. And also I like the fact that they assess fidelity of the intervention and also involved patients, since the beginning, writing the grants and developing the intervention. So that was very, very good. I had a question and also a comment related to what Richard was saying about the population, because I just completed a trial and it seems that the population that I included is not completely different, but very different, because most of the participants in my trial had not been hospitalized, and 93% of them had post-exertional malaise at the study entry. So I think it's okay. I think we need trials, and we know that this population is very diverse and we have different phenotypes. So this is another thing I would like to, congratulate the authors, because I think there has been a lot of discussion in the media, social media, about exercise is good, exercise is not good, and what we need is to do trials and get evidence for it. So because my population was so different, I'm just wondering, Gordon, if you could tell us a little bit, when you did this screening for symptoms, what kind of symptoms were you looking for? In my trial, for example, we were looking for people who had fatigue, problems with mobility, shortness of breath, so things that we could address through an exercise program. What exactly were you looking for? And also, how do you know? This is a question that I often get, and also my team has been thinking. How do we know that in your population, the symptoms that they have, how do we know that is actually long COVID? And we know that the definition is kind of subjective, based, or it's a residual or the impact of hospitalization. And for example, 30% of them were actually in the ICU. And we know there is post-ICU syndrome, and the symptoms can be very similar as well. So how do we know that this population that you included were actually had a long COVID or post-COVID condition? If you have any thoughts about that.
Two very good questions, thank you. I think they kind of go hand in hand, these questions, so I'll answer it as a whole. So yes, 30% of people were in UK hospitals. They were either on ICU or HDU, which is a high dependency unit in the UK. And at this time, this was quite early on in the pandemic, so people didn't know how to treat these people. I know anecdotally less than 10% were mechanically ventilated, so just to give you an idea of the extent of disability within the population. We can't be sure. Don't think you can ever be sure that the symptoms are 100% a result of COVID-19 infection. But we took the approach of participants describing their own symptoms. So we didn't make a judgment as if whether they had long COVID or not. We asked people, do you have any physical or mental health sequelae that you would relate to having had or having been in hospital with COVID and having had COVID? So we were not able to assess that objectively, and I don't think anybody was at that time, and I'm not even sure today there's a way of objectively assessing for long COVID or diagnosing long COVID. So there is the potential that people had symptoms that some of which may have pre-existed their COVID-19 hospitalization or may have been related to something else. We can't be sure. But we took the approach of just wanting to find out if an online intervention of this nature could support people who were experiencing these kind of symptoms.
Thanks, Gordon. Anne.
Sorry, I'm very slow today and my speaking's not good either. I'm just circling back to post-exertional malaise, and I understand that you were conscious of the issues. I'm still taking a long time to read studies, so I'm not completely finished analyzing, but I feel there's not much information on what you've observed. And as was mentioned, we desperately need to have better data on exercise in the subsets of people who do have post-exertional malaise. I'm just wondering, will there be some more discussion around this information? Because there's often in such studies a bias that people having post-exertional malaise with low threshold will not engage in such studies. And this is not clearly explained for most, and people don't tend to understand. So I'm just wondering if there's going to be a bit more of discussion around, because your results are very interesting, but we need to understand more for this subset of population.
Completely agree. And we don't have any additional information that hasn't been published. We we have health economic analysis, but that's not going to answer your question. We have a process evaluation and qualitative analysis that will be published soon as well. Again, probably not going to answer your question. I think perhaps the thing I would say is that actually when we were funded to do this trial, long COVID wasn't even a thing. It hadn't even been labeled, and actually we didn't know that there would be necessarily this kind of post-viral syndrome phenomenon, whatever you want to term it as. So that was why our population was always described as people who had been in hospital with COVID-19, who more than 3 months later were still experiencing mental or physical health problems. So subsequently, long COVID was identified, and our population would fit that badge, if you like. But it wasn't actually our intention in the first place to study people with long COVID or post-exertional malaise. I think it sounds like, listening to some of the other delegates, that some of this work has been done. And I know that Enya's done a study in Leicester recently that hasn't been published yet, which does include people with post-exertional malaise. So I think the data has been collected and hopefully will be published soon. Our study can't provide any insight into that, unfortunately.
And when you mentioned that they were assessed prospectively during, what did you assess during the study, the post-exertional malaise was?
So we had, so very early on in the study, we met with groups from the US and the UK who were involved in the ME/CFS community to discuss how best to assess this. At the time, the feeling was that there wasn't a good objective tool for assessing these kind of symptoms. So they just advised us on the kind of things to look for. Plus we went to the literature and you were able to find a relatively good description of what might constitute post-exertional malaise. So we just worked on that basis. So we spoke to people every week that they attended, whether it be at the exercise session or the support session, to ask them if they had experienced any of these classic symptoms, if you like, that are associated with post-exertional malaise. So long-term fatigue, unrefreshing sleep, these kind of things. So we asked all those questions. And nobody tested to the fact that they were experiencing symptoms to a degree that would possibly suggest post-exertional malaise.
Thank you, Gordon, and thank you for the thoughtful questions, Ian. Rainer.
Yeah, first of all, Gordon, congratulations also on conducting such a large trial. That's really outstanding for a rehabilitation study. At baseline, you reported that 38% of the population was unable to work due to COVID. I haven't seen any data about the follow-ups. Did you also track about the workability after the intervention?
Unfortunately not, which was a bit of an oversight. So we have collected data on employment for the health economic analysis, but we didn't ask the question, are you working now? So it wasn't a predefined outcome measure. With hindsight, it most definitely should have been.
Yeah.
The hindsight piece is always tricky, isn't it? Rich?
Oh, again, I think that you're getting a lot of questions that are on top of a very well conducted study, especially for when it was conceived of. Great admiration, but you're going to get questions. Can you give some more details about the exercise prescriptions that were used? There were one-on-one video sessions, which I think is a wonderful feature, but no equipment. And what sort of targets were sort of suggested for these patients? I noticed there were no exercise outcomes, but the physical activity scores didn't seem to be very impressively and changed. Just give your thoughts on that, please. Sure.
So the live exercise sessions, so we're done on Zoom, as we are now, with an instructor. As it was a decentralized trial and everything was done the participants took part from home. We didn't use equipment, but our practitioners, our exercise physiologists and physiotherapists were very skilled in being able to individualize, personalize exercise prescription in a group, even online. I was pretty skeptical about that, I have to admit, but it actually worked very well, and they were able to do it. The thing that we didn't do, and this comes back to your point about the questions that we always get asked. So the MECFS community were rightly concerned that we would adopt a graded exercise training approach, GET as it's known, which is quite notorious in the literature. And that relies on a progressive, predetermined increase in exercise intensity and duration over a period of weeks, which is absolutely not a personalized, individualized approach. So we didn't take that approach. We personalized and individualized as much as possible. I can't stress enough that the team that delivered this are very, very skilled and experienced in working with all range of clinical populations. The data on improved physical activity was impressive at 3 months, but at 12 months, there was no difference between the groups. So this is classic human behavior, I think, particularly in clinical trials where we do see improvements in the short term in people's participation in physical activity. But nearly always by 12 months, people have reverted to type and are no longer engaging in more physical activity, unfortunately. We didn't do any objective outcomes of physical function because it was a decentralized trial. Yeah.
What sort of exercises were done in these video sessions? You know, walking in place or sit to stand, or
all of the above. So dynamic movements, but personalized. So some people used a chair, some people used a chair to sit on, some people used a chair to support, but just all manner of dynamic movements, upper and lower body. So there was certainly a cardiovascular component to it, but equally a strengthening component. And I think, and you mentioned that perhaps one of the most important benefits that was associated with the intervention was actually improving people's confidence in returning to physical activity and breaking that fear avoidance cycle.
Thank you.
Lindsay.
Thanks, Katie. Yeah, just to echo what others have said. Sorry, really great piece of work, Gordon, and thanks to Enya for a very comprehensive presentation, and your voice just about held out, so well done. Just coming back to the recruitment strategy, obviously is decentralized, which is a really interesting concept. I'm just wondering, of the people who self-referred, how many of those were eligible? And do you think it's sort of a fruitful way of recruiting that you would take forward into other trials?
Yeah, very good question. So the self-referrals were generated from either social media postings, or we also had leaflets or posters for the Regain trial in some GP practices around the UK, but not actually that many. Self-referral pathway was not successful at all. We had about 35 self-referrals out of the 585 people that we recruited. So I was actually really surprised, because obviously social media was very active during the pandemic, but we really had a poor response from social media. In terms of those that were eligible, I think there were, out of the 35, there was only a couple more on top of that self-referred but weren't eligible. I think it's something that we were concerned about in the first instance was, potentially people might just refer themselves to be involved in the study because they were interested. But we did do a check with the participant's GP prior to enrolling them on the study to check they had been in hospital with COVID.
Yeah, and can I be cheeky and ask a follow-up question? On the consort, there was ineligible and not contacted. So how were those groups different?
With the decentralized approach to recruitment, the mail outs when we used the NHS DigiTrials mail out were vast. So 20, 30,000 leaflets went out. So over the period of a couple of months, we had far more online expressions of interest than we could even contact to take through the eligibility process. So those that in the consort that weren't contacted were those people that once we'd achieved our randomization target and actually gone beyond our randomization target, we just weren't able to enroll those participants. So they didn't even get a phone call, which was disappointing but unavoidable. And the ineligible ones would have been people that we had spoken to and for some reason had been determined to be ineligible.
Yeah, thank you.
Tania.
Did you call me? I think Dmitry. Dmitry, did you?
Yeah.
Go ahead, Tania. I'll go after you.
Sorry.
Yes, Gordon, just speaking about the exercise training. So I understood that it was one session per week, which was a group training, and then the pre-recorded sessions through the Beam platform. Do you think, considering that you didn't have a performance-based measure, do you think you can be sure that do you think that they actually improved physical function? And do you know that if they participated in the or if they watched the pre-record and did the exercise through the Bing, did you measure it, the adherence?
Yeah, so the second part, we did measure the number of people who accessed the sessions, the pre-recorded sessions, and the number of times that they did it. And disappointingly, it was vanishingly small. People didn't use them at all, pretty much. So we spent hundreds of hours curating this library of pre-recorded sessions for all abilities. I think we had 40 videos in the end, each of them lasting between 30 and 40 minutes. A huge amount of work by the team. They just weren't accessed. So again, I was a little bit surprised about that, but probably shouldn't have been, because we're humans and this is the way it works. You know, if you have to motivate yourself, it's unusual for people to do these things themselves. But the sessions that were live online and had an appointment attached to them were very well attended.
And
that was a question about whether or not physical
that was
function.
only once a week, right?
Yeah, it was once a week. Yeah. So the subscores of the promise measure didn't show a statistically significant improvement in physical function, but of course this is measured with a questionnaire, which is notoriously poor for actually evaluating physical activity. So it would have been nice to have a physical function measure. I don't know what I think, whether people improved with their physical function or not. I don't know. But it was almost not relevant in the sense that their overall quality of life improved, which was the primary outcome. So that's what we were interested in finding out. And within that, the key things that were changed, the most important thing was fatigue. There was a considerable reduction in fatigue. So that was an important finding. So to kind of answer your question, we don't have a good measure of whether or not physical function improved or not.
So it could have been also because they learned how to pace their activities, and this may have helped them to deal with the activities. And sorry, just one more question about how you tailored and individualized the exercise if it was in group, how practical that was.
Yeah, so this comes back again to our group of exercise physiologists who are very, very experienced and skilled. They had done some online rehab prior to COVID, but it hadn't been very successful. we were thrown into this. We had to do it this way. And as I said, I was a little bit skeptical about whether this could be effective or not, and whether or not they would be able to personalize and individualize as much as was required. But actually they did, and they seemed to be able to do it quite well. So we had a one-to-one session with each participant prior to them engaging in the group live exercise. So they were able to gauge their ability, understand any symptoms and pre-existing medical conditions that may have impacted on their ability to take part. So there was an element of prescription. The groups were quite small, so 6 to 8 people. So although it was a group, it was possible to be individual, so to speak to each person individually during the sessions, to be able to adapt, individualize, and progress things according to their needs. Probably not as good as it would have been if it had been in person, but this is the world that we live in. And I think Enya mentioned the kind of potential advantages of doing it this way were accessibility. For a lot of people in the UK, it's very difficult for them to get to a facility where they can do their rehab. So in that sense, it might have been advantageous.
Thanks, Gordon. Dmitry.
Yeah, thanks for that great study, Gordon, and your team. Getting back to the phenotypes question, I was just wondering, I was a bit struck by the enrollment time after hospitalization. It was around 300, a median days of around 330. That's about a year. I was wondering if there was any sub-analyses, unless I misinterpreted seeing Enya's presentation, earlier on enrollment, like a few weeks after hospitalization, and how those patients may have differed from the ones that were enrolled and with a median time of around a year. I know the groups were balanced, but wondering if you had some thoughts on that.
Yeah, it's a very interesting question. I don't have data on that, so I don't know. We did a sub-analysis on at what point in the pandemic people had been. So in the UK, so we had 4 waves, probably the same elsewhere. So we did that, and there was no difference in terms of people's outcomes. The effect was still there. But we didn't do analysis specifically on the number of days post-discharge. So no, I don't have an answer to that one.
Yeah, no, just it's quite far out. I mean, it may be interesting. That could be some of the differences, for instance, from the other studies and from what Tania is observing. I don't know what the median time is in enrollment. Tania, in your study might be earlier as well. Maybe have slightly different symptom phenotypes.
Yeah, definitely. I'll send the statisticians an email after this. I'm sure they'd be thrilled.
I will check mine right on the chat, but I think it was about 100 days.
Mm-hmm.
Rainer.
So about after the great success of the Regain program, what is the clinical perspective now? Is it also included in the UK in the usual services beyond the study approach?
Something that we're working on. The NHS in the UK moves painfully slowly, possibly unlike in the US or elsewhere, but it's very, very difficult to implement evidence to practice. It's notoriously difficult. So currently, no, but we are having conversations with NHS England about how we might be able to move this forward. So the aspiration is there for this to become part of clinical care. We're actually doing a couple of trials using a very similar approach in different patient populations. So possibly once, if those trials are effective and if we have more evidence, our National Institute for Care Excellence and NICE in the UK might have a look at the data and say, okay, there's a compelling enough case here, both clinically and cost effectively, to consider implementing this in clinical care.
Good, and I think there's a question in the chat from Katherine. How did you assess adverse events in the control group since you did not have contact with them between assessments?
Yeah, so we deliberately had no contact with the control participants during the control intervention period, because we didn't want any contact with them to become an intervention in itself. So the only way we were able to assess adverse events in that group was on the 3-month outcome questionnaire. So we asked people if they'd experienced any issues at all during the period of the control. We didn't do the same at 6 and 12 months. We were only interested in that first 3-month period. So it was self-report essentially.
Thank you. Amanda.
Yes, hello. Thank you again for this great study. It's very, very interesting. I have a question regarding how you measured adherence. So if I understood correctly, full adherence was defined as attending 5 out of the 8 exercise sessions, and which comes up to about 63%. Do you have data on those who adhered 100% of the time versus 63?
So we have the data we need, but we haven't done the analysis. So we haven't looked at those people who complied 100%. So we would have perhaps needed to have defined that a priori, and we didn't. So we defined compliance as you said, 5 of 8 exercise sessions and 4 of 6 support sessions, on the basis that we wanted to look at what adherence would mean for the effects of the intervention based on what we might traditionally see in centre-based programs. So I know Enya said about 80% earlier in pulmonary rehab. That if you're achieving 80%, that's impressive. Our programs are more like 60 to 70%. So that was the reason that we set the adherence targets at that level. So we don't have the 100% data, unfortunately.
Okay, thank you.
That's just in trials, just to highlight, we do not get the same results clinically either.
Good point. We have time for one more question if anybody's been waiting. Oh, great, Lindsay. Oh, it's a tie.
Oh, Tania, sorry. Just got there. I was just going to ask, obviously, we've talked a lot about, with hindsight, what you might do differently. And in addition to that, thinking about how long COVID and maybe pathways and patient populations have changed since you started the study. How would you design a study now? So what might the primary outcome be? How would you recruit? And would you change the intervention?
Ooh.
That's a big one to finish with, sorry.
Save the best for last there. Well, I think we wouldn't investigate this population again. I think we've established that an intervention can be effective in this population, and also established that probably this population represents perhaps 10% of the people in the UK who are who have reported long COVID. So different population perhaps, but I think you guys have done that work now in Leicester, if I understand right. In terms of the trial design and the intervention, I think we would pretty much do things mostly as we did it. It was designed very quickly and implemented very quickly due to the circumstances, but actually most aspects of the trial design worked well. It's a cheap way of doing trials, if you want to look at it that way. But I think the question is, as somebody mentioned earlier, how would this look in clinical practice? That's the thing that I would really like to find out in the future. So would this mode of delivery be acceptable and effective in a clinical delivery population as opposed to a clinical trial population who are inherently biased towards taking part in things?
Well, Gordon, I think that was also a great answer to finish up our journal club. So I just would like to take an opportunity to thank you, Gordon, for coming. It was kind of like a Ask the Author session, and you did a great job, and we really appreciate all that you've provided in the background and kind of how to run a really successful study under some adverse circumstances. I'd also like to thank Enya, Tania, and Rainer for joining us, and for Dmitry for your contributions today. I'd also really like to thank the audience. We had robust discussion, and this was really wonderful interaction in how we want our journal clubs to go. A special thank you to Samantha Carpin from the ATS for all of your help in organizing this. We apologize if you didn't get a chance to ask your question, but please do head to Doc Matter. We can continue the discussion there. We will announce our next journal club in due course, but just to take a quick note, we're going to take a break over the summer, and we'll plan to be back probably around September. Thank you, and have a wonderful day.